Regional Health Authority of Trinidad and Tobago, and he's also the Public Relations Officer of the Trinidad and Tobago Medical Association. And we'll be talking with Dr. Baggan on IT in the health services during the pandemic and beyond. So welcome, Dr. Baggan. Oh, I forgot to say, I'm Jacqueline Morris. I'm your moderator tonight. I am the Vice Chair of the Internet Society Trinidad and Tobago chapter. And with me is Naran, who is the chair of the chapter. So welcome, Dr. Baggan. I'm glad to have you here.
Thanks. I'm glad to be here.
So we didn't have a huge bio. So what I'd say is the first thing I should ask you is, could you tell us how you got into that nexus of technology or IT and medicine, and
how it all came together?
Sure. Yeah, how did you get to be where you are now?
My interest in IT was really just because, you know, as a teen kid, just you just can't help but read. And like, once we got internet at home, I used to have insomnia, so I just wouldn't sleep and I would just read. So I always interested in tech and just all those things about IT. And then when I did computer in secondary school, I was interested in like programming and like all those things. So it became a hobby because my path would have been sort of directed by like family legacies of going into medicine. So I would have gone into medicine, but like, you know, my interest would have, like, all those things would have remained still part of my interest. So I would have always read, and I mightn't be as up to date on like what's going on in you know, the tech world, but I like to know as much as I can about it. So as I went through med school and then working as a doctor, a lot of times when there was like an IT or a tech problem, I would just be the one first on the scene to try and sort it out before we have to actually call IT to try and fix it. Or when IT does come, everyone next to them being like, oh, so how you fix that? Oh, that's why that problem happened. Okay, how can I fix it next time so you don't have to come? So, you know, so it was just an interest. It just kept me there. And then through medicine, I would have probably had that same haphazard career, move from interest in different fields, from hospital medicine, nephrology, eventually realizing that primary care is where I wanted to be. And then I got settled in primary care. And I would say, I think for the last 3 years, in an administrative post in primary care now, which actually saw a lot of that IT come to a head with medicine, because now instead of being mostly about my work being sitting to see patients and, you know, like hands-on work out problems with patients, it is now from an office and from a desk and off of a computer and building systems or changing infrastructure to fix problems rather than individual patient problems, you know. So I think the two things came together in my current job.
Sure. And so you're talking about using IT. I think a lot of lay people don't know just what level of digitization or technology use there is in the health sector. I mean, you were in the Northwest Regional Health Authority. We've gone for vaccinations and had to fill out the paper form the first time, and then they looked us up on the computer the second time, and then we filled out the paper form again. So people have this idea that there's really a lot of paper. Is that true? Is there still a lot of paper and not so many technology-based things in the administration of health?
It still very unfortunately is a lot of paper. It should not be. I mean, I feel from where I sit in health, I look at it and I feel like we still in the dark ages of in terms of getting tech involved in health, compared to like what I would see in you know, in the international health arena, you know. And there is so much resistance. I mean, I was, over the years, long before COVID, I would have sat in different committees where they're discussing electronic health records, and everybody has a reason why it can't happen, and nobody takes the approach of what will it take for us to get it done. And year after year after year that happens. COVID happened, and all of a sudden, within a few months, you just had to make it happen. And all of a sudden we have all these sort of makeshift ways of getting it done. And so it's like we got a flashlight. We went from the dark ages to have a flashlight. Nobody switched on the light just yet, but I think it's going to give us that push for that cultural shift. It's not that technology and electronic records isn't there, but it's not there enough. So like we still use it. So even before COVID, in the administration of primary care, a lot of reports, everything is being done on computers. So the analysis is being done whether on spreadsheets or anything more complex on SPSS. We also would have to collect all that data, but the hub of health still operates on paper. So we always have to struggle to get paper records done and then get somebody else to go in now and pull the information off of the paper, give us the piece we need, work with it digitally, prepare our reports, send it on. But then that gets lost because if you just went for a few pieces of data, nobody is taking the whole record. So 3 years later, you go back and realize, it would be good if we also added a person's past medical history. Somebody now has to go back to look at those records to find that information from handwritten pieces of paper. And, depending on how far back you go, paper records are hard to deal with. And so it's there, but it is so piecemeal implemented. I mean, individually, every doctor has a smartphone. Every doctor sitting in consulting with a patient, we all generally have a number of apps on our phone for like health records or health calculators or things like that. And we would look up and check things or work things out on our phone. So we personally implementing technology in what we do, but it should be smoother than that. It should be a system more where if we record any information on computers and we have electronic records, then those calculations. So if we want to work out someone cardiovascular risk, rather than me having the responsibility of making sure that I have the apps up to date and I doing the calculations for each person, if I was entering records on an electronic system, that calculation could just be done. And by the time I talk to the patient and enter in it, the values that I need to work out should just be present. And I just have to look at it and do the work of interpreting and managing the patient rather than, having to do the actual background to get to that point of the data. So I guess all that is a long way of saying it's there, but it's piecemeal. And the main aspect of health in Trinidad still remains in paper. And anywhere you see tech, it's usually a duplication of what is also on paper.
So we're doing a lot of digitization and not very much digitalization.
Very much so. And if there was an end goal, so there was digitization with the purpose of long-term use and transition, I would have been okay, but the reality is it's still not at that level yet.
It's not even that.
It's not even that. You digitize pieces of data to accomplish individual reports or analysis, and then it's sort of gone after that. It's no longer utilized for anything. I mean, we still use sort of records where sorry, not records, data like outcome data. Not even outcome data, it's more output data, where we just record in numbers. We just record in the number of persons who pass through a health center,
right,
or a clinic or anything like that. And that is so minimal in terms of what data we should be utilizing, and to even get that, it still comes down to a person in the health center or clinic, the clerk, recording the patients who come through, going through the book, counting it up, so that when somebody calls to say how much patients, they give them the number. Now that person will enter the number on a spreadsheet or something, but again, all you have is a number. And
You don't
if
know
you,
who and when and
yeah,
what time.
exactly.
And
You're only narrowly using it for the immediacy of that report to send
Mhm.
on, not the long-term aspects of like outcome management or looking at efficiency or effectiveness in the system itself, you know. So
So
yeah, we have a long
now
way to go.
with the pandemic and the idea that we are asking as a population, we are asking for data.
Hmm.
Do you think that there's a mindset change or a cultural change in the administration of health so that people are now understanding the value of collecting more data and using that data to answer questions about how many people of a certain age got this done when and how and so on?
Yeah, I see it. I think um, it's one of those things where the old heads still though not quite ready to change, but because they forced to change for this specific problem,
Mm-hmm.
they they're getting around to the idea that they could see it utilized. So like I would say, for example, a lot of that is happening for the management of COVID. So a lot of COVID patients are managed via telemedicine, and then those records are also being kept digitally. So they aren't paper records at all being done. They're being handled all digitally, and that has made my life so much easier because at any point, day, night, whenever, I could receive admissions for patients for follow up, even if we not calling them till the next day. I could still prep the file. I could still look at what happening, or I could somebody could message me an issue about another case, and I could look at my database and actually find the links where the contact might have happened through one of our cases or one of our contact cases, because at any point, day or night, I could look at all these things and look at the information. Same way that when we work on it, the doctors who do any telemedicine, we always can't get it done from 8 to 4. So sometimes in the evening, we still call in patients. So it gives that flexibility now that if 8 to 4 was too busy, you could still finish up later on your own, or on weekends. It gives us that flexibility where you could get the work done without having to bring people physically to a space, which was another thing COVID taught us. Physically gathering up in spaces just to accomplish work might not be such a great idea, especially if you could accomplish the same thing from distance and at home, right? So
Right.
it forced that, and it forced the data, because the Ministry of Health needed the data like live. They needed it every day. They needed it when they call, they want the data on on that same phone call. And because it's all digitally, it was so much easier, because I would just have all the things I know they ask for. The formulas are already built in there, so that it just calculating it all the time. So if they ask for a particular number, I know exactly where to look, and it would have calculated it for the day already, and I just have to call it out for them.
Right. Naran, you have any questions? Or Kevon's there.
My question might be a little bit of a slight observation. Um, I know that in some health scenarios, you always have a case of the left hand not knowing what the right hand is doing. So, you might have things being, one workflow really being used in the clinic, and then they get that information is handed off then to the administration. The administration thinks then that this information is collected in a particular workflow, and the two are totally not in alignment at all. Have you seen that in your experience, one? And two, if so, how has that been exacerbated, or how has COVID affected that in terms of streamlining workflows and so on?
Yeah, that is a big issue that still happens. I'm I don't wanna I don't wanna make it seem worse than it is, but is feel almost like not just the left hand and right hand, but the fingers themselves don't know what the other fingers doing. But the as an example, I could say we had a number of projects, so like other health management projects looking at hypertension. And this is a project that was going on from before COVID started. And with that, there's certain data that we have to collect about chronic diseases. So that data has been gathered all on paper because that's the system that they like to use. So that paper collection of data has been oh, sorry about that. Right. That system of collecting the data on paper, and even the way it had to been has to be done is that you have to update, and instead of being able to just update the changes, every year we have to resubmit the same piece of paper refilled out for every patient every year, and that's been going on for a few years. And that data, they say, being collected and entered in a database and being stored, but I have not been able to access it even for me to do my own project plans. And then we had that hypertension issue come up, and the request was for the information regarding hypertensive patients to be submitted. So my response at that sitting, that meeting, was to say, well, this data being collected for the last 5 years, I don't see any reason why it needs to be recollected. Somebody just needs to report the data that they already have. And the response is, well, no, that is a separate thing and somebody else dealing with that. So we have to go back now and go through the notebooks to count how much people have hypertension. And that is what that is what is expected, because every time they implement something, they implement it entirely in a vacuum without trying to integrate it with anything else. And it's so ad hoc in terms of how health systems are in Trinidad that projects get handed down. So WHO or PAHO have some directive, and then that sort of gets handed to the ministry, who then just hands it to the RHAs and say, hey, this needs to be done. In 2 weeks' time, I want a report, right? And then the RHAs themselves don't look at what they already have to get there. They just implement ad hoc an entire new system, because they know that this new reporting stream needs some other information. But because at the root of it, they don't collect information as a whole, like the value of collecting data, because the data will be valuable. They collect the data only because they know that this specific report need these specific numbers, so they go for just that. And that's why every time they implement it separately, it it never they never get to be efficient or effective, because you're duplicating the same project over and over. And I've had so many things that is like that. The only advantage that COVID has brought really is still only narrowly applied to COVID. So the COVID management of patients gets that efficiency, it gets that effectiveness. So when we move from unvaccinated country to starting to have vaccination, and we needed now data on vaccinated patients, or the impact of vaccinations on outcomes and all those kind of things, because we already know that we're collecting data on all the patients for every file. It just became, well, we added this new column, and we just is a new data point to add to the same files that we already have. So when we made the calls, it just became one added question that day, and it quickly added into the system and now stored. So as we need to tweak it, the data already collected. As we need to use it for something else, the data is already sitting there waiting. So that showed us the value of it. And I mean, I'm very glad to get to do that for COVID. I really want to get to do those kind of things for all the patients, and that's where I want to see us go.
Now, there's one thing that I've noticed a lot is that you say that there's projects that people do, and then that's that project's data. That is something that I've noticed. We as Trinidadians we kind of like to hoard a little the information. Is that something that happened, that you think that COVID has started to break down that, to say, okay, this information is not my project's information. This information is for use. And if that is so, would that impact on any major, because we hear that we've got the digital health coming, we've got a Ministry of Digital Transformation. Obviously, health is huge in this. Would that be, do you think that's something that's there enough that it would make an impact on how they have the, well, in the RHAs and the Ministry of Health and basically the whole health system looks at their digitalization projects?
I feel like the people who there now, the people all in place, generally still have that culture of sort of like hoarding and hiding the data. And I think it is much more encouraged in health systems than maybe other places because they're so focused on the concept of confidentiality and protecting patients' data that they've sort of extended well beyond the limits that confidentiality really should be applying to.
So let me interview you a second. Does that mean that do the RHAs share information? So if I'm in Port of Spain General and I have to go to, and then I go to Arima Hospital, do those two RHAs share information?
Totally not. So when you reach Arima, for the Arima person to get any information, they need to get you to go back to Port of Spain to ask somebody there to write a letter on paper to send it back to them for them to be able to take that information and stick it in another paper file that they have. And that's still even in the height of COVID, I still face that. I have so much challenges where a person who live in my county, so I'd have to manage them, but they got their test done somewhere else. It is like a headache and sometimes weeks, sometimes it's not even worth it just for me to get a copy of that result. Half the time I tend to tell the patient, hey, what? You're doing well, you're gonna get discharged on so and so date. When you get discharged, you go back there and you ask them for the document because I can't even get it. So even now we still face that challenge. There really realistically is no sharing that goes across the RHAs or even within the RHAs. If you went to Port of Spain and you come to a health center within the same Northwest RHA, none of that Port of Spain information is accessible by anybody in the health center. And we have to do the same thing. We have to send you back to Port of Spain to ask them to write a letter to send it back to us so that we could know what happened. Because there's no other way for us to know what happened.
This is just kind of mind-blowing because I'm kind of looking
that's why I keep saying we are very much in the dark ages and we really only have a flashlight. We haven't turned on the light yet. We still in the dark ages in health.
I don't know if we have a flashlight or if we have a candle that we haven't lit yet.
Yeah. The unlit candle is probably the better analogy. Yeah. I would say they have made decent attempts, right? Like so Northwest did a project that I really was behind. Like I was real interested in where they implemented an electronic health record in St. James Medical Complex. So it was primarily for pharmacy and for the oncology department and so on. But it was a very interesting, at least to me in my little tech hobby side of myself, it was an interesting project. I think the company was Newfield Technologies, but what they did was they implemented a health record that was based on blockchain, and the health record, the actual ledger and so on for the block is held by the patient. So the patient has their record in their app, and it is secure because it is blockchain. It's you can't tamper with it because you would have different levels of access of who could actually change the ledger. So the doctors and the nurses would be the ones who could change it, but the patients would be the one who have full access to view it. And so I looked at that, and conceptually it came at a time where over the years when blockchain was coming up and I was so interested in it, I was not interested in the cryptocurrency. So I was like, to me, that was not an interesting use of it, but the technology seemed so interesting to me that I was like, this has to go somewhere, and this has to go somewhere big. And so when I saw it going into health records, I was like, oh, it clicked. That is a genius system for this type of technology. I've seen something randomly on my phone recently, where they have like safe or secure file sharing, where they're using the same kind of concept with blockchain. So you share a file with someone, but because it's shared, you could still revoke access because you're not really sharing the file. It's still just a single ledger, which means it eliminates that whole issue of you share pictures or you share files or whatever with anyone, and they make copies and they send it all over, and now you can't get your data back, except now you could, because you could lock it at the source and then nobody else has access. So all of those were things that I thought was so brilliant in terms of that technology. And seeing Northwest do that in St. James, I kind of thought that, oh, this is going to expand and this is going to spread. But then it got shut down from the perspective of ministry, said that any RHA could do their own attempt at a health record, but it can't be implemented until they decide what will be the actual system for the national health records. So you could do all of these as pilot projects only, and then it can't go anywhere more than a pilot until they decide what will be the national health record system. And as far as I could tell, from the last 10 to 15 years of their meetings and discussions, they have not been able to settle on a system. And every time they kind of lean towards one particular system, it start to either go obsolete or the cost factor start to become prohibitive for them, and then they back out. So I mean, I think the closest we got right now is Selma, which is across the country. As far as I know, it's across the country. So most RHAs have Selma, which is an electronic health record. You could store all sorts of information into it and share, but they don't want to pay for the additional modules to store all of that. So all that gets stored is patient demographics, their address, that kind of information, and visits. So it's more of a glorified appointment system. So that idea of how you was seen in Port of Spain and then you show up in Arima, using Selma could see that you did go to Port of Spain, but they still can't know anything of what that was or what happened. All they could see is you went to Port of Spain on this day and you have appointments for these clinics scheduled. That's all. So maybe you could deduce some things, but I mean, we shouldn't be like playing detective with people health records, right? It should be easily accessible across the board. So wherever a patient access health, they should be able to get the doctor to review all of their record. And like I said, that's why I thought that system that they got with the blockchain was going to be brilliant, because every patient would have their whole record, and anywhere they go, they could have access to it, and the healthcare professionals could look at the whole record, but I don't know when they will settle on a plan.
It does sound a little scary that I go to the health center and they don't know if I'm, I fall down in the street and they rush me, and I go in the health center in Digger, for example, and they don't know how to treat me properly because they don't know what my allergies are. They don't know what my history is, if I have any sort of heart or diabetes. They wouldn't know any of that.
Yeah, they won't. That's sometimes why I know patients get frustrated, because you go to see doctors and they all basically asking you over the same information over and over every time you go. And it's kind of usually because each time you see somebody and they're going through all of it again, is because they just don't have access to the information. So unless you give it to them, they're not going to know, which forces you to have to relate it over and over and over.
An observation that, sorry, Jacqueline, an observation that I think too with the dispensaries within the hospitals and the emergency care, etc. For example, I have a good friend. She lives St. James, but one of her clinics that she attends is in Mount Hope. And of course, leaving St. James to come all the way up to Mount Hope for clinic is one thing. But then every month when she has to go to the dispensary to get medication, it's a next story, because one, you go to the dispensary, depending on the hour, you have to wait at least half a day sometimes, because there's so many people. And there is no way that she can go, because when she asked, okay, I am living St. James, can I go to the Port of Spain General Hospital dispensary to get my prescription filled? They said no.
Yep.
You know, you have to do it here. This is where your clinic is. You have to do it here. I mean, even if that was, you know, in some general system where you don't have to go to a specific dispensary and you could just go to the one nearest to you. Because I understand there are some clinics that are in specific areas.
Yeah, that is exactly how it works, unfortunately, and I think that patient probably has it even worse, because not only what you describe, where she goes to Mount Hope and can only fill her Mount Hope prescription in Mount Hope, she may also be having follow-up for other things, say her chronic disease, and that would happen in St. James. And then St. James would issue a prescription for those meds, which she have to spend her half a day in St. James to fill that one, and then take a next half a day to go to Mount Hope to fill the meds for that one over on that side.
Actually, yes, that is exactly what happens to her.
Even within the RHA, it's almost as bad, because if you have sort of a hospital prescription and you come to the health center, sometimes they have a challenge being able to fill those as well. So then instead of being able to give you a 1 month supply, they get 1 week or 2 weeks. And then now they have to come more often, or be told to go to Port of Spain and sit down there for that half a day, come to the health center and sit down for that half a day, and then go to Mount Hope and sit down for that half a day. And as I say, it feels like it could have easily been corrected by having a singular record across the board, because then you could record who dispensed which meds out of the prescription, and it saves you from problems as well, because you also have the opposite situation where they're struggling to get their meds to begin with, but you have some patients who say they have Alzheimer's, or they have some other dementia, or they're just forgetful for any other reason, and they fill their prescription in one place, but then they went to another place to fill the same prescription. But because each place that you go to also write in your prescription, so you might find yourself in 3 or 4 clinics, and 3 or 4 clinics write in prescriptions, and some of the drugs overlap and some of it don't, and you go in and you fill in it, and you're being told to fill it in all these different places. Each of those places not aware that, well, you picked up one of your hypertensive meds in the St. James clinic, but it also written in your health center clinic, and now you fill it in that one as well, and then you went Mount Hope, and that same drug was also on their prescription, and then you filled it there, and it just so happened that all 3 of them had a slightly different brand, so the box looked different each time, and the patient who goes home didn't realize that the different boxes was the same medicine, and now they took 3 doses of the same drug, and that in itself is, that, as far as I'm concerned, dangerous. That's far more dangerous than even just the inconvenience to the patient, right? The patient shouldn't be inconvenienced anyway, but at the same time, we move in from a level of, oh, it's just an inconvenience that we're trying to solve, but no, it's not. It's an actual danger to people's health that we're not addressing, we're not dealing with it. And then they would argue about other issues with stealing, which can happen, but I would say that is such a smaller percentage, where a patient would get multiple areas to write a prescription and fill it so that they get multiple meds and then sell it. It has happened, but the cases, I mean, it's like you could count on your hand how many times that happened in a population of 1 million people. So, the reality of creating a system to block that is irrelevant compared to creating a system that's convenient to people to move everywhere. And that's one of the excuses why they tell them that, oh, because you got it written in Mount Hope, you have to go there, because they feel like if you come in multiple places, you might be filling a prescription multiple times in order to sell the drugs. I'm not saying that is the excuse, but I've heard that as one of the excuses.
Sitting down every time.
Yeah.
Kevon has a question.
half a day. Yeah, Kevon has his hand up. Kevon, do you want to ask a question?
Sure, I'll ask the question. Good evening, everyone. I'm on this side this evening, but I'm enjoying the conversation. I came in a bit late, so I may have missed some things. Keegan, I'd like to ask, so it really deals with the technologies behind health administration. Number of years ago, over a decade, government had plans to come up with national identifiers and have it integrated with an item that a typical citizen would have, maybe an ID card. And with these national identifiers, you would have been able to access or at least store personal information, and particular sensitive personal information, such as your health records. And of course, the idea, or at least the policy behind data protection law, would have been that there could have been a waiver in cases of being incapacitated, that a health professional could access all of this. I want to know now in 2021, so I'm talking about past knowledge that and past cases that I was quite familiar with. Now in 2021, where are we in this country in terms of these health technologies, the possibility of implementing, for instance, a number of authentication schemes, perhaps username, password, and a token of some sort, or a single password, deploying potential, whether it's websites or apps, mobile apps, or apps that are web-based. Where are we in terms of implementing some of these technologies to really manage health information and facilitate the training, and of course, all in compliance with the data protection principles of the DPA? Is there some ingenuity? Is there anyone who is clamoring for this within the health sector from an administration standpoint?
Okay, so if the project that you might have been talking about, if I remember correctly, I think that was when they started to try to roll it out for CDAP, right? I mean, they had bigger plans for it, but I do remember they did try, and they had a whole sign up, and you was gonna get a CDAP card, and then that card was meant to link to your health records, and that was gonna be sort of the unique identifier.
Yeah, that was a specific application of it. Yeah.
Right. Yeah. Exactly. That was like just one subset, but as far as we could tell, all those projects, just like the hands that was interested then that push it, when those hands move, the whole project just drops. That's kind of what happens with health. So they've gone back to having nothing. That's sort of where they're at. The closest that you've gotten that I was thinking of is Selma. That's where they have, because the ministry paid for it, or each RHA I think had to pay for it. So each RHA has Selma. So a patient, you're supposed to be able to have a unique Selma number separate from your patient number, because all health records here is still all completely paper. It also means that every time you attend in clinic, you might have a clinic number. So if you're in 5 different clinics or 10 different clinics, you have 10 different clinic numbers. So none of your clinic numbers uniquely is you. You have several clinic numbers. And then worse yet, if you come and they couldn't find your file, well, they either start a new one or they do a temporary one with another clinic number on it, right? And all of that was intended to link eventually to a single Selma number. It exists, so the Selma still exists, and they still use it for appointments. So they use it quite a lot right now with the vaccine appointments. So they enter the information on Selma, and it's supposed to have that same unique number. But again, what happens is, if a person can't quite find your name, they just sort of create a new number, and now you end up with multiple Selma numbers, just like you have multiple written records. And so then that is another problem. But all it's been used for is appointments, because they have not digitalized anything with the overall health records, and because that still remains handwritten pieces of paper in stacks all over the place. None of that has moved into a phase where you could link that to a person's unique number, whether it's Selma or whether any other system. They just haven't gotten to anywhere close to that. And I think, like I said, the closest I saw was when they did roll out that portion with CDAP and implementing that card. And then eventually that just fell apart. And then never bothered with and never continued.
Okay, that's an interesting case there. And I have a follow-up question. Agnostic to digitization, are there policy obstacles for sharing information among health authorities? So, for instance, DP law would talk about having comparable standards for the storage and processing of data. So outside of the challenges to digitize, have there been discussions about these comparable standards? What will happen between one health center and a hospital and all these things? Because I understand everything is very manual. I mean, that's a shocking thing in this time of the year of the pandemic, that we're still very much manual. But have there been discussions?
Sadly, I sort of tired of the fight then, if I should say. Not that I've lost the zeal for it yet, but that fight is sort of like years and years on, right? And as you say, in terms of comparable standards, the fact is everybody's standards are so poor that it's all comparable because nobody has a standard that is anywhere close to it. I mean, realistically, records simply disappear because it's paper. It's stored in wherever it's stored, in a room somewhere that happens to flood one day, right? So, and that sort of is just what every other RHA does. So every health center is like that. Every hospital is like that. Everywhere there's a clinic or a health system for Trinidad, it is still that way in terms of just those paper records. And in the past, I would say there was so much resistance. I've gotten every excuse to, down to the point that records used to tell me that it's against the law for them to store things digitally, and that they have no legal framework for electronic records, which I then found the law in the Evidentiary Act and showed that it is stated quite clearly how to submit electronic records into evidence. So you can't say that having an electronic record suddenly makes it illegal to store. So I mean, they've come up with so many different reasons every time that I'm not sure if anybody knows the true reason why the health system has refused to move forward with digitalizing their record keeping, because the excuses become different over time, and I'm pretty sure the excuses that come up is because everybody was handed that excuse from before. So every department, whether it's the records department or the nursing department or the legal department, all have the excuses that was handed to them. And nobody would sit and go and say, well, if you're telling me that, where's the law that says that? Where's the policy document that says that? I tend to do that a lot in my slight middle management position, where I would go and search for the documents, and if you can't find it, then I will say, well, these are the standards. These are the standards elsewhere. And even if some RHA does something innovative in a small way somewhere, I would take that and say, well, now I have precedent. If they could do that, I want to do that and take it to the next step. So you still get that resistance to the change, and I think it's that cultural, that inertia to change, because I don't think, I mean, a lot of younger people and younger workers happy for it, because once they see that it makes life easier, they're very comfortable. I mean, I could say just with the COVID transition, even when other RHAs went digitally sooner, we kind of lagged. And well, our county, not the whole RHA, but our county lagged, and there was a lot of resistance. And then by the time we were forced to do it, because the wave became so out of hand, there was no way to keep up. And so I had to like create the transition while mid management of all of it. Now they're all so happy, because now they realize, oh, well, I could work from home, or, oh, well, I don't need to come in to go through stacks of paper, or, we're trying to figure out who is the contact of this particular index case. I no longer have to pull out the 500 files that we have to see where the slip of paper is that wrote down the names of who they were in contact with, because now it's all on databases that we could cross-reference with each other. And so they're all on board with it. And even, I would say, even the staff who aren't as like, comfortable with technology, and even just simple things like using a fillable PDF form that I would have created. They're not so comfortable with that, or Word documents and typing and all that. I'm getting them around it, and they're seeing the value of it. A lot of them still prefer, they will do their pen and paper and stuff like that, and maybe transfer it over after their handwritten notes, but they do see the value in it. So I don't feel that on the ground, like the actual people in the trenches kind of thing, I don't think they're the ones who really resistant to the change. I think it's like the management level, because they aren't. What happens at that level is that they receive what they need, because every time they say they want X, they don't have to figure out how X gets to them. It just happens because everybody on the ground finds a way to make it happen, and they get it done. So they don't quite have that drive to say that, well, we should get better, like what, get better, even just saying get better for better's sake, for no other reason, and that, right? Not even to say let's solve problems, let's just say let's improve, just because iterative improvement is the way to go, right? That's the only way you keep up with the future. But they feel like they get what they need done, and they don't want to push beyond that. So then that's where it just stays. So all the excuses get handed down, because they were told that this was the reason why it can't happen. But why bother to check? You know? And that's what we see. And I do think that even when COVID is finished, we're gonna go back to still fighting those fights, right? Because what they've done now is still a very ad hoc method of solving this information and health records and stuff like that. It's not really a complete system, or even an appropriate overall health record system. It's just very much an ad hoc interim solution. But I do hope it gets everybody on board with the idea that, look, this concept makes sense. I mean, just because we got the okay in doing it for COVID, I started implementing it in terms of a lot of my other data analysis and data reports that I have to keep track of, and even simple things like just staffing that I have to track. I start putting it on shared formats so that myself and the other PCP2, so there's three of us who work at that middle management level, sort of. So rather than us have to sit and work to share to have the files shared that we work on the computer, we only accessing it when we on the network there. But now I use the same platform that they're using for COVID, and I kind of like add some sheets and I add some spreadsheets onto it, and like I tack on other things, and now we have access to what we need, for ourselves at any day, hour, night. Because COVID showed us that as well. Like the work in health doesn't really stop, especially when you're in crisis. So it doesn't matter that is 1 o'clock in the morning. That might be the time that I get a free moment, that I need to put in some other things in place, so that who will be there at 8 o'clock could make sure that they have the data to run with, and they're not sitting waiting on information for them to start their process flow. So all of those kind of things is like, it gives us the flexibility to do more and get more done at like, random hours, random places, off of your phone. I've loved that fact that now that I can now access a lot of this. I could be preparing reports or writing up things anyway. So I could be in the middle of a health center because I'm reviewing another project to make sure something else is running smooth. But, I can't physically get back to, instead of wasting the time, to physically go back to the office just to type up a document, I could sit right there before I leave the health center and type the document. So by the time I get to my car, is because it already been sent, So the convenience of so much of the things we've used individually and we've implemented individually, but they have not adopted it as a policy, and that's where it's always going to fall short, because I like using the tech. Not everybody like doing it like me in my own office. So there will come a time where I leave that office and I'm somewhere else, and a lot of some of those things will disappear. Even some of the things that I implemented. Now I felt like I was doing real good. I implement all these new analysis streams and all these things. And my CMH came and he was like, 15 years ago when he was working here at that same position, he implemented some of that and he went and collected data and he went out and pulled it out from the patient files and entered everything. And he would have left over 10, 15 years ago and moved up in ministry. And he come back and he see me implementing it like if it brand new, and he was like, so what happened to all this stuff he did then? And I was like, well, I came and I met nothing here. So I mean, the ideas needed to get done. That same way he needed to do it 15 years ago, the same way I needed it now. But there was no continuity.
I think this is something that I have noticed on and off, maybe in the 15 to 20 plus years, that in and out of the healthcare, because nothing technology already exists. I remember demoing a system 10 years ago for somebody, same blockchain idea, but digitizing everything automatically, interfacing with the X-ray machine, interfacing with the blood test machines, and pulling that data straight into it. Being able to use multiple, this was designed to be a Caribbean-wide platform. So it was designed to take multiple national IDs, right? For the sole purpose of if somebody does not have their identification, the system identification, that you can do a search on a national ID. And it had smart contracts implemented into it. So automatically, if somebody came in injured and was non-responsive, the emergency surgeon, who had that privileged access, could enter their credentials, state a reason, put in the national ID, and the system would do a search, pull up the personal information with a picture so that if possible, the surgeon could verify it's the correct person, and then it would unlock, what they're allergic to, who's the next of kin to contact in the case of emergency, if they have a DNR order, all these kind of things, and all of those things were automatically unlocked in the system, so, and that was 10 years ago, so it's not a matter of technology. I think it's just that you have to have a culture that is willing to embrace that change and, realize how much time and effort and, how much more efficient, the whole system could be. If you're not wasting 90% of your day doing paperwork and you can actually do what you're supposed to be doing, it frees up a lot of time and it makes the quality of life for the workers as well as the patients better. But, you have to, the culture, like with most of the conversations we've had, I think a lot of cases we have seen that is not necessarily technology is falling down, but we need to have a culture shift, and not just like a one-off where it starts, but that has something that is continuous over a long period of time.
Well, one of the things that happens with the culture change is that you may change the minds of people, but if they leave, that mind goes with them, as Keegan's been saying. But what we don't like to do is implement process change. Because if we can put processes and procedures in place, so when someone leaves, the new person comes in and finds these things already institutionalized in the way people know this is how my job is to be done. And we keep making sure that when we introduce people, when we orient new staff, they learn this is the process. Then that is how things can continue. And we don't, because culture is people, and people move and change. And if you move out a department and get new people in, the whole culture changes. Sometimes you don't even have to move everyone. You move a manager or a head or a VP, and the entire culture can change in months. And that is not, we talk about culture a lot, but we don't talk, but that is not what is the foundation of locking in that change.
I think actually, Jacqueline, what you mentioned with the hoarding, I think that does link back to that as well, because I think what happens too is that a lot of times somebody comes into a position and makes the changes and gets things going, and they view it as having achieved the cultural change, but they sort of it's their baby, you know. They've done it, and they've made this, and they work so hard at it, and it's so hard to let go of it, you know. And it's like, so then now by the time they hold on to it for so long, you get to the others on the outside start to lose interest, and then by the time that person goes, nobody's there to take up the interest. And like, I think just from a like professional development kind of perspective, which have nothing to do with tech, but so when I got promoted to my position, it would have taken a little settling down to adjust to like a new way of doing work. So let's say a couple months I spent doing sort of making that adjustments, and then sort of looking at what things could improve. And then like my next project within the first year of me getting that was to actually start looking at all the doctors who now work under me and trying to identify who is the next person who could take my job, who is the next person who could move up and take the same position from me, and how could I encourage them and sort of groom them and like get them into like the things that we want to implement, and the ideas of improvement. Like I a simple thing like complaints was it's still a battle, right, with quality department. And I've been trying to get the perspective of people to change, to realize that quality is not about complaints for berating people. It's about process management and about making efficiency and effectiveness your goal. So like, don't treat quality as your enemy. You know what I mean? And like, just that little cultural change, and like I said, trying to get those below me to see little things like that, so that, you know, there will come a time when I leave and I move somewhere else, and somebody will move up into this space. And I'm hoping that some of those ideas come with them, so that like all of these things aren't completely lost. Because, you know, I just, so like, it's one thing to like do well and create this great project and do something innovative and new, but the real test of it is sort of being able to do that and then let it go for somebody else to run with it. Because if you could get somebody else just as interested running with it, then you know you really built something, versus you did it and you built it and it looks good. You know, it's about that next generation that comes. How do we get them into it, and how do we get them taking it to another level that I couldn't think about? You know, and it's like, so it's always like I said, I take that as a professional development approach, not just like a tech thing. So you same way like the person who would have been above me as the general manager, by the time I was coming in, the general manager was actually my uncle at that time when I was now entering the health system. And I remember within the first few years of me working and settling down as just the bottom level primary care doctor, I would tell my uncle, you know, well, I would learn from him. So I mean, I looking to learn everything about that job, which is sort of at the top for primary care in Northwest. So I still have a few steps before there. But I remember telling them early on, I was like, you know, make sure you hold on to that seat and keep it warm for me, because I will be coming there eventually, right? But you know, it's like the aim is to keep improving where you are, move to the next level, and get others to take over what you were doing before, so that there's never stopping that growth. You know, the growth just keeps going and building and building. And I think that's what will get that cultural change. But it is hard. It's hard to get everyone behind it.
That is the absolute hardest part of any kind of transformation. We have a couple of minutes more. So if anybody has any last minute questions, please get them in. And one I would like to ask you to basically start wrapping up is, so we are going to come out of the pandemic. It's going to go from, I guess, urgent to endemic. And we will live with COVID as we live with all the other viruses. But what will happen, do you think? What do you want to happen, or what should happen, or what do you think will happen with Northwest Regional in particular and the rest of the health sector with regard to digital transformation? Where do you think we should be? Where do you hope we will be in 2025, for example?
Okay. I I know it'll be ambitious to hope that we at the level of an electronic health record. So realistically, I'm not going to expect that. But I actually feel like in that time frame between now and 2025, given the hardships of that cultural change in a RHA, I do think we can achieve certain levels of digitalization. So I feel like we should be able to move away from duplication of a lot of processes. And even if we still collecting information on paper, I see that I want to see that the same practices that we were doing now in COVID, where the staff have access to relevant information at home, or well, I mean, using the technology anywhere really. We don't have to necessarily get to the point of having patients' full health records, but if the actual data that we use to make decisions, like population statistics, patient, like percentages of patients who well controlled, those are things that does not impact confidentiality. Those are aggregate numbers, but the management still treats that as if it's a big top secret piece of information that nobody should have. And I want to see, I think in that time frame, I could see that opening up. And if that opens up, then I could get a lot more of the outcome measures rather than output measures being put in place, so that we could start making decisions based on patient outcomes, because the data in aggregate being collected and kept and shared, because it's the sharing that matters. Because if we have it, and because there is a division for data within our RHA, all RHAs have it, HPRP, health policy research, no, health promotion, research and policy, right? So they're the actual branch assigned for data and collection and analysis and research, but they do the same attitude of like hoarding it and refuse to share the information. So if that alone would open up, because they still have digital records of aggregate data that was moved from paper files, and if they just move to that level of openly sharing that within the organization, then that alone is a big transformation that we could make, because we could implement programs that have actual outcome effects rather than implement programs because arbitrarily it sounds good. Because that's where we at. We still at somebody said this is a good idea, so now we need to do it, and there's no collection of data to actually show that the outcome went well. And the pilot project that's supposed to let you know that just continued forever, and it's never really left the pilot level, but also never improved. So like I said, that one piece, if I could see that in the next few years, and I do feel like the experience of COVID would have opened that idea up to a lot more people. If I see that change, I could see a lot happening in health just for that small change.
Niran, do you have anything to wrap up with?
No, I think we covered everything more. I'm not even going to go into talks like in terms of like big data and artificial intelligence and things, because I think that is way outside of what the capability is right now, given the way things are. But part of the reason I wanted this talk was a lot of people, through one channel or the another, has been saying, well, they don't understand, why things are so slow, and what are the bottlenecks and so on. And I keep telling them, I say, things are not as coherent as you all think it is. So I think this was a very good discussion, to show where we are at present. We know where we like to go, but it's just kind of, doing the change management, if you will, both procedural and cultural to get there, and I think people will know once people begin to see the benefits of it. That's the thing. Everybody, my philosophy is everybody's inherently selfish. So what's in it for me? And if somebody could see that, they don't want to spend half the day chucking paper, that they could actually do other things, tension, it reduces the tension to adopt these technologies, but you have to get over that initial hump. It's always that initial hump. The first step is always the hardest. But once you get them on the road, it tends to get easier.
I mean that as the stone starts to roll, it will inertia.
Mm-hmm.
Yes,
inertia. Our wonderful laws of, anyways. So, but then of course the question is, when we're rolling it up the hill of digital transformation and COVID has given us a push, we need to get it to some sort of inflection point where we can rest for a bit before we go back to the old normal, because there's so many people who are hoping for the old normal and not quite understanding that we've moved to a new, that there is going to be, things are never going to go back to how it was.
Yeah, that is such a good point. Just in health management, it's never gonna go back. Just our concept of mask wearing is something that is unique to us in terms of this side of the world, but it's not unique to Asia. It's something that they're doing for decades, and to them it's normal. And for us, it's such a hard fight because it's that up the hill push that you're talking about. You just have to get there to that inflection point and go over to the other side.
Yeah, and once we get there, I mean, I have allergies. Niran has allergies. We know a lot of people with allergies. We are not going to stop wearing masks, because we have not we did not realize just how wonderful it is to not breathe in that Sahara dust.
Yes, and that Sahara dust gets worse and worse year by year.
Absolutely. And a mask, yes, we put it on because of COVID. But when Sahara dust comes, there's so many people I know who are going to back out that mask and continue wearing it because it's nowhere near as bad as dying from the Sahara dust. So that's one long-term change that we already see with some people. And then, of course, there's the work from home that's that's quite a few people want to continue. And there's a lot of things that are never going to go back because we've had a taste. And I hope, honestly, you've scared me so much with some of these stories about the medical thing that I really hope that what we've got from COVID will act as a new floor and we can move up from there. And say thank you very, very much for spending time with us. It's been fascinating, a little scary, but there is space for hope. You've given us ideas that, yes, there are people who understand that change is needed. And I'm so happy that there are people like you in the health service. And I think that would be it for us for tonight.
Who's our next speaker?
Next week, we have the new CEO of the IFC. His name is John Outridge, and he came in last week.
Yes.
He's very new.
Yeah.
And he'll be talking about fintech, because we've all heard a lot about it, but we don't really know what it is. And no, it's not about cryptocurrency and things, but there's a lot going on in the region. I mean, we've got the Eastern Caribbean and I think the Bahamas are both doing central bank digital currencies. And nobody really understands too much about it. So he's going to come talk about all of that and where that will lead us post-pandemic.
I think that sounds very interesting.
But yeah, come back.
Yeah, I definitely would love to, Naren. You'll have to send me the link for that one.
Not a problem.
Yeah, we need to know. Really, we're hearing about all this, but we're moving into a digital space. Everybody's doing digital transformation, and where does fintech fit into the digital Caribbean post-COVID? So that's next week, 7 o'clock, John Outridge. And that will be our 10th in the series.
Yes.
We've been doing this for 10 weeks. Every Thursday, except for the Thursday we had the ICANN meeting. So thank you everyone for participating. We had some good questions. We had a great conversation. And we'll see you next week with John. Bye.
Bye, everyone.
Bye all. Be safe.